Welcome everyone to our third CAFTR sponsored SBR webinar, and I'm very excited. You all know Geoff, but I would still like to introduce him. I'm delighted to introduce Dr. Geoff Goodman as our presenter. Dr. Goodman is an associate professor of psychology in the Long Island University Clinical Psychology Doctoral Program. Dr. Goodman is director of the Long Island University Children's Institute for Play Therapy and Research and coordinator of the Long Island University Clinical Psychology Doctoral Program Applied Child Research Team. He is also director of the Norbert Friedman Center for Psychoanalytic Research at the Institute for Psychoanalytic Training and Research, IPTAR, and serves on the IPTAR Board of Directors. Dr. Goodman is also the former chair of CAFTR. He is a licensed clinical and school psychologist and a psychoanalyst treating children, adolescents, as well as adults. He is also a certified sex therapist, certified sex addiction therapist and supervisor, certified multiple addiction therapist and supervisor, and registered play therapist and supervisor. Dr. Goodman is the author of many articles on the development of psychopathology and psychotherapy process in high-risk infants, children, and adults. He has many books on attachment theory, such as The Internal World and Attachment, Transforming the Internal World and Attachment, and Therapeutic Attachment Relationships. He has also conducted extensive work in Uganda, establishing and evaluating an intervention program to facilitate the development of school readiness skills in preschool children, and published Rural Community Libraries in Africa, Challenges and Impacts. Dr. Goodman has also published extensively on the use of the child psychotherapy process QSET and adolescent psychotherapy QSET. He has given multiple trainings and workshops on the use of these measures around the world. He has also trained my research team in Turkey on the use of the child psychotherapy process QSET, and it was a wonderful training. Today, Dr. Goodman will be presenting his paper entitled Expert Clinicians Prototypes of an Adolescent Treatment, Common and Unique Factors Among 4 Treatment Models. I'll leave the floor to Dr. Goodman now. Just to let you know, there will be 30 minutes at the end of his talk for questions and comments, but you're also welcome to write your questions in the chat box, and I'll be tracking the questions and let Dr. Goodman know. So, Geoff, the floor is yours.
Thank you, Sibel. And I trained Sibel's lab in the child psychotherapy QSET back in January of 2017. It was one of the greatest experiences of my life. Sibel was so gracious in taking me around Istanbul, and we did a lot of sightseeing, and it's a tremendous city, and I love to go back sometime. And I see Claudia on the call here, and I trained her team remotely for the first time just a few months ago. And that was also a great experience, although I missed going to Chile, but I hope that we can make that work soon. So I'm going to be talking about an article that I co-wrote with Ana Calderon in Chile, and Nick Midgley, who's at the Anna Freud Center and University College London, about the adolescent process, psychotherapy process QSET. This is the first paper that I published using the APQ, the Adolescent Psychotherapy Process QSET, but I have published previously on the Child Psychotherapy QSET and the adult version, which is the Psychotherapy Process QSET, AKA the PQS. So I'm going to walk you through this paper and explain what we wanted to accomplish and what we did accomplish and what we found. But I thought I would start off by talking a little bit about how I got involved in Q sorting. You know, I was reflecting on my experiences with Q sorting and realized it's really dominated a large part of my professional career. And in my home university at Long Island University here in New York, You know, people often, you know, joke around with me that I'm the Q sort man, and you know, I'm synonymous with Q sorting, and why am I so obsessed with it, and all of that. Um, I I became aware of Q sort methodology way back in 1992. I attended a workshop as a postdoc um, conducted at Harvard University by Avshalom Caspi, who's a very famous developmental psychologist. And he first introduced me to the methodology at this workshop that I attended. And I subsequently developed my own Q sort and did work in Q sorting, but it wasn't until 2005 I attended a conference of the American Psychoanalytic Association, believe it or not, in Seattle in the spring of 2005. And a postdoctoral student of Stuart Ablon, her name was Ty Katzenstein, she was presenting on the psychotherapy process Q set. I had never been exposed to it prior to then, but her findings that she presented at that conference really just woke me up. And I realized I really wanted to do something with this Q set. Serendipitously, I had a mentor at Cornell when I was at Cornell who bequeathed to me a very rich data set of 5 patients hospitalized for borderline personality disorder. The total number of sessions was 127 among these 5 patients. And the receiving of this very rich data set of transcripts combined with my exposure to the psychotherapy process Q set for the first time was very serendipitous, because I realized this is what I want to do with these transcripts. So many years later, I published a series of articles using the psychotherapy process Q set. But I was very interested in finding out whether there was a child version of this Q set, because I was primarily a child psychologist. At that time, it had a lot of child training, and I had a master's degree in developmental psychology, and wanted to find out whether such a thing existed. And if not, maybe I could create a child version. So I talked to Stuart Ablon, who at that time was really the curator for the adult version, the psychotherapy process Q set. And he said, yes, there's a woman at UC Berkeley in California here in the United States who has worked on a child version of the instrument called the CPQ, or the Child Psychotherapy Process Q set, and that I should get in touch with her. And her name was Celeste Schneider. And, you know, Celeste and I developed a friendship and collaborated on an article in 2016, and, you know, worked very hard on using the CPQ. And I think I became the first lab to use the CPQ on actual data, child videos. And so I published my first article using the CPQ in 2011, and have been publishing using both the PQS and the CPQ ever since. And that's kind of what I'm known for, Q methodology. So in 2012, I joined Nick Midgley and Anna Calderon in London to conduct a training on the CPQ with Celeste Schneider, and Anna and Nick conducted a training simultaneously on the APQ, the Adolescent Psychotherapy Q set. And so that's when I got to meet Anna Calderon. And a number of years later, you know, I approached them and asked them whether, you know, we could maybe publish an article on the APQ using prototypes, which I'm going to be talking about today, how we did that. And we eventually started working on this article, and you know, I assumed the role of first author on the article, and it's in press now in Psychotherapy Research. So it should be coming out in print, I guess, fairly soon. Who knows with Psychotherapy Research? But I'm very happy to present this research based on the APQ, which is the last of the trilogy of Q-sort psychotherapy process instruments. So I'm very excited to share the findings that we collected over the past couple of years. I do want to make a plea for everybody on this call to join CAFTR, the Children, Adolescent, and Family Psychotherapy Research Special Interest Group of the Society for Psychotherapy Research. I'm the former chair of the group. Sibel, who's our host, our moderator, is the current chair of this special interest group, and I think it's very very exciting and interesting to join our group. We meet all together at the annual conference for a lunch. We also have a listserv that we belong to, and we're actually starting up a journal club. So if you sign up and join, you can be part of the journal club. We have a lot of exciting things going on. So I just wanted to make a plug for for CAFTR and joining the special interest group. It's free of charge. There's no special payments. If you're a member, I think, can you join CAFTR without being a member of SPR, Sibel?
Yes, you can.
Okay, so you don't even have to be a member of SPR. You can join CAFTR without being an actual member of SPR. So I encourage everybody to consider that possibility. In recent years, we've also made it a point to represent child psychotherapy research at the annual conference every year. And I think we've done a pretty good job of getting some exposure that way. Certainly, we have a lot more child and adolescent psychotherapy research presentations going on now at the annual conferences than we did when I first joined SPR in, I think it was 2010. So I'm happy about that, and I hope everybody considers joining CAFTR. So with that, I am going to share my slides. And if anybody would like a copy of my slides, I'm happy to send them to you. My email address is ggoodman@liu.edu, and I will send those to you. Can everybody see my slides? Okay, great. So, I think everybody is familiar with the idea that child and adolescent psychotherapy treatment models are effective. They help children with their symptoms, and we're familiar with the research. There are plenty of meta-analyses that have been conducted that demonstrate that child and adolescent psychotherapy work. But we don't know as much. What we don't know about as much is why they work. How do they work? What makes cognitive behavioral therapy or psychodynamic therapy work for adolescent children? And that's where this kind of research that I'm going to be presenting to you actually comes into play. And we used 4 treatment models to explore the idea of what makes these models work. How do they work? Are there distinctive aspects of these 4 treatment models? Are there any common factors going on among these 4 treatment models? So we asked these questions, whether we could identify 4 distinct treatment models based on experts representing these models. And we wanted to find out whether this concept of mentalization, which I've been writing about for a number of years now, whether this concept of mentalization spans all 4 treatment models, and whether we could call mentalization a common factor. Of course, there's such a thing as mentalization-based treatment, first written about by Anthony Bateman and Peter Fonagy, and we know that it's been extended to to children, MBTC. Nick Midgley and his colleagues wrote a book about that particular treatment model. So it is a specific treatment model, but my question is whether this concept can be found in a variety of treatment models, not just MBT, but also PDT, CBT, IPT, which is interpersonal psychotherapy. And so these were some of the questions that we brought to this study that Nick Midgley and Anna Calderon and I, conducted. We wanted to know whether this was true for adolescent psychotherapy. I had already shown through previous work that it was true that mentalization was a common factor among a variety of treatment models in child therapy and in adult therapy. I published an article in 2013 in the Journal of Psychotherapy Integration for adult prototypes that demonstrated that. And then in 2016, Celeste Schneider, Nick Midgley, and I published an article that demonstrated the same finding in child psychotherapy. So I wanted to see whether this was true in adolescent psychotherapy as well. So we believe that mentalization is a common process factor. Let me describe a little bit what I mean by mentalization. It's commonly thought of as the ability to read other people's minds, right? So through people's behaviors, nonverbal facial expressions, gestures, tone of voice, all of these signifiers, if you will, suggest to us underlying mental states that people have in their minds. So if I were to bang my fist down on the table like this on my desk, you might wonder, maybe Geoff is feeling angry right now. So we make these inferences, right? And that's what mentalization is all about. But can we really read people's minds? Not really. One feature of mentalization is the realization that people's minds are ultimately opaque, meaning that we don't really know what is going on in people's minds. We can't be certain. All we know is some evidence that we can collect through these nonverbal and verbal features or signifiers, which gives us a clue about what might be in other people's minds, but we don't really know ultimately. The more specific definition of mentalization is the interpretation of people's behavior as resulting from underlying mental states. So what are their underlying intentions, beliefs, feelings? This is the essence of the idea of mentalization. And Bateman and Fonagy, way back in 2004, first wrote about mentalization as possibly a common factor that spans a variety of treatment models that would also explain the effectiveness of all these treatment models. Like I started out the webinar by saying that we know that child and adolescent psychotherapy is effective, but we don't know exactly why. Well, one hypothesis is that what makes all of these treatment models effective is their common usage of mentalization. And so I wanted to explore that idea in these very diverse treatment models. Okay, we're good so far? All right. So let me talk about the actual, or actually familiar with Q-sort methodology. So it's a methodology that uses a variety of items. You could think of Q-sort methodology as sort of like a Likert type scale. You have a number of items that are rated on a rating scale. In this case, a scale from 1 to 9. The difference between Q methodology and Likert type scale methodology is that in Q methodology, you have to make sure that there are only a certain number of items rated with a certain rating. So in the case of psychotherapy process Q sets, the trilogy, this PQS, the CPQ, and the APQ, they're all 100 items. And the rating scale goes from 1 to 9, 1 being least characteristic of the session that you're rating, 9 being the most characteristic of the session that you're rating. And in the ratings 1 and 9, only 5 of the 100 items can be rated least characteristic. So they're given a rating of 1, and only 5 of the 100 items can be rated most characteristic with a rating assigned of 9, and then all the ratings in between. But so one way of thinking about Q methodology and the characterization of psychotherapy process is that these 100 items are a vocabulary that we're using to characterize an infinite variety of sessions that you might want to code or understand from a psychotherapy process point of view. So each item is like a vocabulary word. So it's like taking 100 vocabulary words and writing an essay or a narrative about the session that you're wanting to rate. And you can arrange those items any way you want. So there's a great diversity of arrangements that you can use to characterize a session using this limited vocabulary of 100 words that characterize the process that you're observing in the video that you're rating. So it's a common vocabulary that articulates different types of process. So the arrangement of the items in this 100 item Q set can serve as an operational definition of a particular treatment model. And that's how we used the Q set in this study that I'm presenting to you right now. So it's 100 items distributed in 9 piles, right? And the normal distribution is 5 items in piles 1 and 9, 8 items in piles 2 and 8, 12 items in piles 3 and 7, 16 items in piles 4 and 6, and 18 items in pile 5. And as you can probably deduce, that creates a normal distribution that then you can apply normal parametric statistical analysis to. You don't have to do any log linear transformations or anything like that. The APQ then is applied to a 45-minute audio recorded or video recorded session. So the unit of measure is a 45-minute session. It's not a microanalysis where you're looking at specific turn taking within the session. It takes as its unit of measure an entire 45 minutes. So we consider this a molar measure rather than a molecular measure of process. And the APQ is applied to sessions of adolescents ages 12 to 18. So there is some overlap at the lower range with the CPQ. The CPQ, the child psychotherapy process Q set, is designed to measure process in sessions with children ages 3 to 13. So the APQ is designed for ages 12 to 18. So there is some overlap at ages 12 and 13 there. You can make a decision whether you want to use the APQ or the CPQ. And these 100 items you can consider to be capturing different facets of psychotherapy process. So about 1/3 of the items tackle therapist attitudes and behaviors that you observe in the session. About 1/3 of the items tackle patient attitudes and behaviors in the session, and about another 1/3 of the items kind of capture therapist-patient interactions, what they're actually doing, saying, how they're behaving toward each other in the session. So the APQ is previously shown to have convergent and discriminant validity with Hills and Roth's comparative psychotherapy process scale. And what we did in this study was we wanted to collect ratings from experts in each of 4 treatment models. So typically there are 2 ways of using Q sorts. At least there are 2 ways I've used to collect data using Q sort methodology. One method is to collect a series of psychotherapy sessions, either from a single case study or from a multiple case study. So in my own research here at New York, I usually do single case research where I look at a patient over a long, a long-term psychotherapy treatment, and I train a team to code sessions in that one single case, and then I've collaborated with Sibel on research in which we're looking at many cases, many treatments of children in research, and there are obviously different statistical analyses that you would use in those 2 different scenarios. But it's basically just looking at a session and then Q sorting what you observe or what you see in that session. That's one way of using Q sort methodology. The other way that you can use these instruments, and this is what we did in this particular study that I'm presenting, is that we asked experts in these 4 treatment models that we use. So it's PDT, that's psychodynamic therapy, CBT, that's cognitive behavioral therapy, IPT, which is interpersonal psychotherapy, and MBT, which is mentalization-based treatment. We asked these experts in their fields to use the APQ to define what would be known as an ideal or prototypical session from their own particular theoretical perspective. And in fact, the instructions that we gave was to each expert was to rate the items as you see this process occurring within a prototypical adolescent psychotherapy session from your theoretical perspective. So those are the actual instructions that we gave to our experts, and we gave them an honorarium of $150. This research was funded by the International Psychoanalytic Association, and then I took each of the ratings within a theoretical perspective, and I composited them. It's not rocket science. I just added up the ratings and I divided by the number of raters. So in 3 of the 4 treatment models that we looked at, we had 10 expert clinicians. So we had 10 for PDT, 10 for CBT, 10 for MBT, and then we could only get 9 experts for IPT. That's why we had an odd number of 39 rather than 40. So I just divided by the number of experts in each treatment model, and then we got a composite for each of the 4 treatment models. And so what do these composites mean? These composites are what we would consider to be, which the experts would consider to be the ideal treatment model from their perspective. So we have these 4 different composites. Everybody follow me so far? Any burning questions right now before I get into the results? I see Oslam gave me a thumbs up. All right. So the first step we took was to find out whether the ratings kind of hang together, whether they agree with each other. So I went back to the individual ratings of each of the expert raters, and I looked at the internal agreement using alpha coefficient for each of the 4 treatment models. And the internal agreement was very good for all 4 groups of expert clinicians. So that was the first step. The second step was to conduct something called a Q-factor analysis. And what that means is that I treat the ratings of each of the raters as variables. And I conduct what would be a principal components analysis, but I'm not conducting the analysis on the items. The items are considered like subjects. So they're the rows, and the columns are the ratings of the expert raters. And so doing it this way, what we found was that the factors turned out to be the raters that you would expect for the most part, except for the psychodynamic experts. The psychodynamic experts seem to span, they seem to load onto more than one factor. The IPT folks generally loaded on one factor. The CBT folks tended to load onto one factor. The MBT folks tended to load onto one factor, but the PDT folks tended to load onto more than one factor. So I've written it down here in my slide. 3 of the PD, so remember there were 10 PDT raters, expert raters. 3 of them aligned with one IPT rater and one MBT rater. 5 of them loaded onto their own unique factor, which is great. That's what we actually expected. But then another 2 PDT raters aligned with one CBT rater, one IPT rater, and 7 MBT raters. So you see that half the PDT raters loaded onto 2 other factors. So which we weren't expecting. What we were expecting is that each treatment model would they would hang together, the raters would hang together. And for the most part, we found that except for the PDT expert raters. They spanned different factors. So the second hypothesis that we tested was, so the first hypothesis was, can we actually distinguish 4 different treatment models? Do the ratings hang together among these 4 raters? And for the most part, they did. PDT, though, there seemed to be a little bit of confusion, but overall, we felt that the first hypothesis was supported. The second hypothesis was whether these treatment models are uncorrelated with each other, or whether they're significantly correlated somehow with each other. And we had hypothesized that the treatment models among these different experts would be uncorrelated with each other. They'd be very distinctive. Why did we hypothesize that? Well, we relied on previous research that had been conducted that indicated that that would be what we would find. Let me explain. So in 1998, Stuart Ablon at Harvard Medical School and Enrico Jones at Berkeley, UC Berkeley in the United States, collaborated on an article that was published in 1998. And that was the first known article publishing on prototypes. And they collected prototypes of PDT and CBT in that article. And I won't go into the details of what they found. It's a landmark article, and it's a touchstone for this type of research. It's a brilliant paper. I think it's one of the greatest papers published in the last 25 years. That's how I view it anyway. And among the findings is that the CBT and PDT prototypes were unrelated to each other. They weren't correlated with each other. They're very different styles. The processes that are going on are just not correlated with each other. And then we try to replicate those findings in 2016. Nick Midgley, Celeste Schneider, and I tried this same idea with the CPQ. And what we found in the CPQ is that PDT and CBT work significantly correlated with each other, believe it or not. And we reasoned that in child therapy, all child therapists are trying to rely on more common factors of establishing a relationship, getting to know a patient, playing with the child. Therapeutic alliance might assume a greater importance working with children than with adults. And so specific techniques of CBT and PDT might be less important working with children. And remember, child therapy is less verbally mediated as well. It's more how you interact with the child behaviorally, and whether you're emotionally sensitive. And I think all child therapists tend to rely on the more what we would consider to be common factors. And that's how we explained the significant correlation between CBT and PDT. But with APT, we reasoned that adolescent therapy is probably more verbally mediated than child therapy, that adolescent therapy is more related to talk therapy. I mean, I think of the adolescent patients that I treat, and, I'm not typically playing with them. Like, they don't play with Play-Doh, they don't draw, they sit and they want to talk to me about what's going on in their lives. And so the type of therapy that I typically do with adolescents is more talk mediated. And so I thought, well, maybe because of that, these specific techniques that are germane to CBT and to PDT would be more captured in the prototypes that the experts sent us with their APQ ratings. So we had reasoned that APQ prototypes would be more similar to the PQS, the adult prototypes, than the child prototypes captured by the CPQ. So we thought PDT and CBT would not be correlated with each other, more similar to the adult findings from 1998 than the child findings from 2016. So we did that, and contrary to our expectations, PDT was very significantly correlated with CBT. And in fact, all four treatment models were significantly correlated with each other. And I have the table, and we'll get to that a little bit later. I'll show you the table of the correlation matrix. And what we found was also that in looking at this correlation matrix, that MBT had the highest mean correlation. So, I calculated the correlations between MBT and IPT, MBT and CBT, MBT and PDT. I did that with all four treatment models, and MBT had the highest mean correlation with all the other treatment models, which was in support of our idea that mentalization, whatever that means, and I tried to define it a little bit for you earlier, that is a common factor, that all treatment models tend to use mentalization, whether they know it or not, whether they're conscious of it or not. They tend to use mentalization in their interventions with adolescents. So I want to take it one step further and find out whether, if I control for MBT in using partial correlations, whether the relationship between PDT and CBT, the relationship between PDT and IPT, and the relationship between CBT and IPT still exist, or whether they go away after I control for MBT. So I conducted these three partial correlations. And what I found was that the relationship between PDT and IPT did in fact go away. It became non-significant when I controlled for MBT. And similarly, the relationship between PDT and CBT went away, evaporated when I controlled for MBT. However, the relationship between CBT and IPT remained very significant even after I controlled for MBT. I thought, oh, that's interesting. So in previous work, we've shown that MBT is a common factor across all treatments. And in fact, MBT was the most highly correlated prototype among the four prototypes, the correlations among the four prototypes. However, when I controlled for MBT between IPT and CPT and CBT, IPT and CBT remain significant. So how do we explain that? So, I've been thinking this through, and I spent a lot of, if you're interested in reading the article, I spent a lot of time in the discussion section trying to figure this out. So I'm going to show you tables 1 and 2 in a minute, but MBT process could not account for the correlation between CBT and IPT. And what I did was I proposed 2 common process factors that exist in these 4 treatment models. And, obviously, these ideas cannot be extended beyond these 4 treatment models. So there are other treatment models besides these 4, right? There's DBT for adolescents, which is dialectical behavior therapy. There's TFP for adolescents, that's transference focused psychotherapy, Kernberg's treatment. And there are plenty of other options. I think there might even be ACT for adolescents, acceptance and commitment therapy. They're all different kinds of treatment models, as you're probably all aware of. And many of these treatment models have been modified to accommodate adolescents, right? So I'm not talking about any others, just among these 4 that we did explore and investigate in this study, we found what I call 2 common process factors. One is providing mentalization, which is consistent with previous hypotheses that I've made in previous work. But then there's another common process factor that couldn't be explained by MBT, which I believe it holds CBT and IPT in common with each other. And I call that providing support. Now, what is providing support? And I'm using the Enrico Jones language here to define what I mean by support. It's not support like in the common term of I support you. It's a very technical term that means advocating, it's advocacy for the patient, kind of like a cheerleading. You can do this. I know you can. And also adding guidance and advice. Now, if you're coming from a psychodynamic point of view, and I would identify myself as a psychodynamic clinician, we don't typically give advice or guidance. We don't engage in cheerleading or advocacy for our patients. We might throw that in occasionally. I don't want to deny that I've ever used these interventions ever in my life. I certainly have, and I don't want to be rigid about the types of interventions that I make. Just because I'm psychodynamic doesn't limit me from using other types of techniques or interventions with adolescents. But what I'm doing here is I just want to identify 2 perhaps distinctive process factors that might be going on here. And between CBT and IPT, what might be the common process factor between these 2 otherwise distinctive treatment models is this idea of support. So let me continue with this discussion. So what we found is that the adolescent treatments are more similar than different due to these common factors. And we wondered, well, so why is adolescent therapy behaving more like child therapy than adult therapy when we're looking at the overlaps or the correlations among these 4 treatment models? And we wonder whether maybe there is a little less talk therapy in adolescent therapy than in adult therapy. Like maybe it's more like child therapy than adult therapy, or at least in how these experts conceptualize the prototypical or ideal versions of their 4 treatment models. And then if we buy into this idea of 2 overarching common process factors of mentalization and support, if we buy into this theory that I'm proposing here, we can then ask ourselves the question, which of these 2 common factors is more effective for what kinds of adolescents under what kinds of conditions? So might support be more effective than mentalization for certain types of adolescents than others? Under what conditions? In a hospital setting versus an outpatient treatment setting, so we can ask these kinds of questions, or treatment phase, right? So maybe support is more important in a treatment, early in the treatment, and then gradually mentalization, common factors, interventions can be introduced in the middle and later stages of a treatment, right? So if you think of, and this, I make this argument in the discussion section of the paper, if we think of mentalization and support as being the opposite ends of a continuum, right? So can we move the needle depending upon the type of patient we're treating, as well as the treatment phase, where we are in the treatment? So we might start out with a patient who, let's say, has externalizing behavior. We might start out with the needle pointing more closely in the direction of support. We're advocating for this patient, we're cheerleading, we're encouraging. And then gradually, as the treatment progresses, we move the needle closer and closer to mentalization, where we can actually then kind of help the patient to explore other people's minds, including the therapist's mind, and what might be going on in other people's minds and their own mind, and how that might be related to behavior, and doing the more kind of exploration that's more synonymous with mentalization-based treatment. So if we look at this at this as a continuum, I want you to start thinking about how we might use these 2 different ideas as polar opposites that we can then titrate depending upon the type of patient in our office, the treatment phase, and also where we're seeing this patient, whether it's in the hospital, outpatient, school setting, wherever it might be. So just something to think about. I think there's a question in the chat. Sibel, you want to take that?
I don't see it, Geoff. Unfortunately, you see a
Okay,
question
let me.
in the chat?
It's
Maybe
from
I'm missing it.
Andre, and
I don't know why I can't see it.
oh, okay. So Andre just said he has to leave soon. I thought it might have been a question. All right. Thank you for
Unfortunately,
coming, Andre.
I can't see the
Oh, okay.
questions in the
All right.
chat for some reason. I'm sorry.
Okay, no problem. I'm almost done here with presenting. So these are some ideas I have about these 2 common factors that I'm hypothesizing based on our findings here. And it's an assumption that what's common between IPT and CBT is support. I'm hypothesizing support because I'm relying on the work of Enrico Jones and Stuart Ablon, who wrote in the early 2000s about what they believed was common between CBT and IPT was this idea of support, that the correlation between the IPT prototype and the CBT session prototype in adult treatment anyway is I think it was 0.54, which is very significant. And maybe you're thinking IPT, well, how would that be related to CBT. It's very different. And what Jones and Ablon argue 20 years ago is that these two forms of treatment are only superficially different from each other. Their content might be different, but the process of support is very similar. And so they look very similar. If you look underneath the hood of these two treatments and look at their actual process, the process is very similar. And what they argued was that what makes them similar is this idea of support, which I'm using in a technical sense, not in the common jargon sense of support. So I just wanted to highlight that. How can you use these prototypes? So I have the prototypes. If anyone wants to use them in their own research, you can certainly, Sibel wants to use them. You can certainly email me and I'll be happy to send you the prototypes that we created. But you can take these prototypes and you can correlate them with your session ratings in your treatments that you're studying, and you can get a correlation, just a Pearson correlation between the session ratings and the prototype ratings, and that will serve as a session adherence rating. So you have a Pearson correlation, and that can tell you the magnitude of session adherence to a particular theoretical model. And what I like about the Q methodology is that you can simultaneously calculate adherence to multiple treatment models with the click of one button. I can tell you how adherent a session was to these 4 different treatment models right at the same time. So it's really cool. And then you can take these correlations and then you can then in turn correlate them with outcome measures to find out how correlated the session adherence is to outcome measures. So, and there's some literature that suggests that session adherence is probably has a curvilinear relationship with outcome. In other words, if you're very loosely correlated with adherence to a treatment model, it probably outcomes suffer. And if you're too rigidly correlated with or adherent to a particular treatment model, outcomes also suffer. But if you find that sweet zone known as the Goldilocks effect, not too little adherent, not too much adherent, if you find that sweet spot, that Goldilocks effect, that's where you have the maximal impact on outcomes. But the APQ permits people to conduct these kinds of studies. And that's what I think is so exciting about Q methodology and having these prototypes at your disposal. You can answer these kinds of questions, particularly which treatment models are most effective for which patients, for how long too. So you can conduct follow-up studies to find out how long your outcomes are effective for. You know, are there sleeper effects with certain treatment models? Do certain treatment models continue to provide benefits and improvements in patients long after treatment has been terminated? This kind of research really has the potential to answer those kinds of questions too. So let me just take a few more minutes to show you, these are the correlations among the 4 treatment models. And you can see they're all very highly correlated with each other. This is table 1. All the prototypes are very highly correlated with each other. And if you were to take the means of all of these with each other, you'll find that the MBT, this 0.76, 0.80, 0.75, that's the highest mean among all the 4 treatment models. And we go to table 2. These are the partial correlations, which I decided to do after we actually had already formulated our hypotheses. And you'll see that even after controlling for MBT, these correlations between PDT and CBT and PDT and IPT go away. They're non-significant. They're almost zero, actually. But after controlling for MBT, the CBT and IPT correlation is still very significant. I mean, it's less than it was in the previous slide, which is 0.882, but still it's very significant. So that's what leads me to believe that there's something else going on here that explains the relationship between CBT and IPT other than mentalization. These are the specific items that are most characteristic of PDT and least characteristic of PDT. Your therapist works with young person to try to make sense of experience. You're thinking, that sounds more like a common factor, and you would be correct, because this item 9 is most characteristic of all 4 treatment models. And so actually the ones that don't have asterisks here are the ones that are unique to PDT. So therapist pays attention to young person's feelings about breaks, interruptions, or endings in therapy. So what we found was that the unique aspects, the secret sauce of PDT is a focus on feelings. That's what we found mostly. The secret sauce of MBT, there was no secret sauce, basically. I mean, there's a little bit here. Therapists ask for more information or elaboration, right? But these items are basically shared with at least one other prototype. CBT was a focus on thoughts and symptoms. So if you see your item 39, therapist encourages young person to reflect on symptoms. That was unique to CBT. And then of course with IPT, the unique focus was on relationships. So therapist encourages young person to try new ways of behaving with others. Item 63, young person discusses and explores current interpersonal relationships. That was unique to IPT. So those are the unique aspects of IPT. So there was some uniqueness, but overwhelmingly, these 4 different treatment models had much more in common than they had distinctive with each other. And that's what I want to emphasize today, that in adolescent therapy anyway, what unites us is stronger than what divides us, which is more like child therapy than like adult therapy. And with that, I will stop my share and entertain questions. Don't be shy.
I would first like to say, Geoff, thank you so much. This study is so clinically rich and relevant. First of all, I'll just say a few comments myself. I have a few questions as well, but I'll leave it to the floor for questions first. But I want to say, first of all, I'm very excited that prototypes are available to us now. Because I've used, with your direction and with your training and with our collaboration, I've used the prototypes derived from the child psychotherapy Q set in my research extensively, and it really makes process research rich. So we can answer what is psychotherapy effective, but we can also answer with the prototypes the change mechanisms. What really happens in the sessions, what works for whom, so we can answer really nuanced clinical questions, which is so exciting. And I think your research for the first time in psychodynamic adolescent therapy has very important implications for common factors as well as specific factors. And with that, I have a few questions myself, but I'll first ask our audience if they would like to ask questions about their feedback.
I guess I was really clear.
I'll start and maybe they could, the questions may come up. I'm very interested in this finding of PDT experts being divided into 3 factors in your analyses. And I want to hear your thoughts on that. Why do you think that is? Is that because of the nature of PDT, or do you think it has something to do also with the nature of APQ? One thing I have noticed when we use the APQ is it's different, a bit different than the CPQ and the PQS. It has less of the interpretive items of the psychodynamic approach. We actually were obsessive with one of my thesis students, a very gifted student, Barishcan, with whom I published on the APQ. And we compared items between the CPQ, APQ, and PQS. And we found that APQ has less emphasis on defense interpretations and interpretations in general. And I wondered if that also made it harder for PDT therapists to ally with, one unified decision. But I would love to hear your thoughts.
I mean, that's an excellent question. I have a bunch of thoughts about that. I did want to say, someone in the chat asked for my slides, Antonella Sirasola, but I don't have her email address. So I'm not sure how.
Yeah, I know, I have.
You have it. Okay, great. So if you could.
We will be doing the journal club together and I'm in contact with her. So I would be happy to share your slides if you send them to me.
Maybe what I can do is I can send them to you and then you can distribute them to Antonella. So thank
Absolutely.
you. So let me try to answer the question, just several thoughts that I have about it. I mean, my knee-jerk reaction would say this has much more to do with PDT itself than the instrument. But in truth, I don't have any reason to say that other than my experience with PDT. And that is that, I went through psychoanalytic training at the Freudian Society in New York, but I was exposed to a number of different theoretical orientations within the umbrella of psychodynamic theory. So, Freudian theory, ego psychology, object relations theory, mentalization theory, relational theory, self-psychology. I think the problem with psychodynamic theory, which has been going on for a number of years now, is that we have so many different sub-theories within the umbrella of psychodynamic theory that it's hard to really define each one independently of the other. And Peter Fonagy makes this point very clear in a number of his writings, but particularly his 2003 book of psychoanalytic theories of developmental psychopathology. It's one of my favorite books, and I use it in my child and adolescent psychopathology course here at LIU. He makes the point that there's been a proliferation of psychodynamic theories in the field, and there's been very little way of being able to determine which theory is a good theory versus a bad theory or a better theory. And he actually mentions Q-sort methodology in that book as a way of trying to determine which theories are superior to other theories within psychodynamic theory, because there's been this proliferation. And I think that in the process of recruiting psychodynamic experts to our study, this particular study that Nick and Anna and I conducted, we might have collected ratings from experts in different theoretical camps. Maybe some folks were relational theoreticians, others might have been more traditional Freudians, some might have been more ego psychology, some more self-psychology. And so their ratings reflect their particular theoretical perspective within psychodynamic. But when Q factored, conducting a Q factor analysis, their ratings wouldn't hang together in that sense, because there's such a diversity of opinion within the psychodynamic realm. So that would be my initial response. But then you talked about the instrument itself, and there I feel less equipped to answer the question. The reason is that Anna Calderon is the one. Anna and Nick really developed the instrument. I came on sort of late to the game and was more involved with the development of the prototypes due to my expertise in that area, but they're the ones who developed the items, and I can't speak for them regarding how they developed the items. But it's very interesting. I didn't know that you had done that cross comparison among the three Q sorts. And is that published data, or are you planning? It is. Okay.
We published that.
If you could send me that, I'd really love to read it.
Absolutely. It's interaction structures in adolescent psychodynamic therapy. And we were trying, Özlem, I'll come to you in a second. We were trying to understand, because we had a similar finding to yours, that we had a distinct technique factor that emerged in our study, and it was psychodynamic, like reflection on and mentalization focus, reflection on thoughts, feelings, deepening them, attention to the relationship. But then we were looking for the interpretive items. Where are they? And that's when we compared the instruments to see, does the APQ have the interpretive items that were in the other measures, because they have come up in my previous research with the CPQ. And we found that there is less emphasis on interpretations and more emphasis on exploration, mentalization focused work, which we also found to be very prominent in adolescent work, like you did. But we wondered, about the use of the instrument this way.
Right. No, that's very interesting. Which of those two hypotheses is correct? I'm not sure. We might want to go back to the data. I don't know whether Anna actually recruited these experts. And I wonder whether I know that she had administered a questionnaire along with the actual items to determine, more of the expert characteristics. I know one aspect that we collected was how many years of experience did they have in the field. So we had that information. But did she ask the experts of PDT what particular, flavor of PDT did they tend to practice in their own private practice? I'd have to go back and ask her whether she collected that information or not. She's the one who actually collected the ratings. It's an excellent question, though.
So Özlem has a question.
Yes, Özlem.
Wanting to ask.
Hi, unfortunately, I need to go in a minute because my 10:15 patient is about to come to Zoom probably, but she's not here yet, so I just wanted to comment. I wanted to say great presentation. First of all, thank you. And it makes a lot of sense that it would align a little bit more with the child processes. It made me think, like, I am a psychodynamic and attachment-based, and within that umbrella, I see myself relational and attachment-based. And many of my adolescent patients actually have narcissistic parents, right? And we can formulate it as like they are actually under a lot of stress, maybe even under psychological abuse. And since they live in that household at that time, like when they're 15, 16, it is harder to do psychodynamic work. And I find myself tending to do more support and individuation. so that they can get through that process of psychological abuse. And I have a few patients whom I've been seeing since they're 15, now they're 20. And then I start doing more psychodynamic work with them to understand what happened to them and where their patterns are coming from. As I also know their parents from the child adolescent work, because I had parent sessions. So it makes a lot of sense that they would align a little bit more, supportive work, maybe individuation, maybe even advice giving. As I'm thinking psychodynamically, but is the patient ready for that interpretation? Many times not. And when they're 20, if they stick around, then I slowly gently introduce the ideas. Yeah. So I just wanted to say that.
Yes, and that is consistent with what I found in some adult research that I conducted with some borderline patients. What I found was that, and these were actual patients, we're not talking about strictly prototypes here. These are actual patients that outcomes were improved the greater the therapist use CBT interventions. These are PDT treatments, by the way. So the more, and this is like in the first 6 months of the treatments. These were long-term treatments. This is when patients could spend much more than 6 months in a hospital setting. That's not possible now, but when the data were collected, that was possible. So in the first 6 months, therapists who used more CBT interventions had patients who did better than the therapists who used more PDT at the beginning. So we argued that these patients weren't sophisticated enough or stable enough, I should say, to make use of PDT interventions early in the treatment. And these are PDT treatments. So Özlem, what you're saying fits completely with my research findings in an adult sample. Now, the question is whether we could actually demonstrate that in an adolescent sample. So I think it remains to be seen. I mean, Sibel might have some data that would speak to that in her very generative lab, very productive lab.
Very productive, yeah.
Thank you. No, it's gonna make our research a lot richer to have the prototypes. So it's a great collaboration. But we also found in the paper that I mentioned that using too much expressive psychodynamic technique, increasing the dose too suddenly created a negative therapeutic reaction. So I
need to go now. Great.
Thank you,
Özlem. It's good to see you again.
Great seeing you.
Any other questions?
I think some people had to step out, but there are wonderful comments in the chat also, Geoff, who would like, Vera likes to receive the slides, and I have her email as well. And
okay, great.
Hi, I'm sorry I couldn't speak before, but can I ask something right now?
Yeah, absolutely, Maria.
Thank you. Well, I just heard Sibel, and she mentioned that something that I find quite interesting, because I live in Argentina, and here we have a strong sense of psychodynamic therapy. And Sibel, you just mentioned that the an excess of terms of psychodynamic therapy could have a negative impact. Could you please develop that a little bit more? Because I feel quite interested about that, because I've read similar things before, but I don't have like enough information. So I think it's quite interesting.
That was something actually we found in the paper that I mentioned, which we published using the APQ on a data set of 40 adolescents who were in psychodynamic treatment. And it actually aligns with something Geoff said. what we did is using this APQ, there are various ways of using the APQ, which also Geoff mentioned. One is the prototype tradition. The other is to find interaction structures, meaning therapist behaviors, child behaviors, and relationship characteristics that characterize the whole treatment. So we try to extract interaction structures from these treatments. And this is done with a factor analysis. And we found a factor in our research, which we named psychodynamic technique. It wasn't heavily interpretive, but it didn't have the supportive advice-giving traditions, and it was very much oriented towards expressive psychodynamic interventions. And we found that if they were not timed well, especially with patients who had more complex comorbid disorders, who had higher levels of psychopathology, it could have an adverse effect. My sense is, just like Geoff said, initially some adolescents, especially ones that have higher levels of psychopathology or more complex psychopathology, may need more supportive or maybe mentalization adherent work before going towards more expressive and interpretive approaches. So a stage model could be appropriate for them, which would be work for future research. So, but that was what I found in my research, which is also something I see clinically, especially with adolescents who are in a more severe identity crisis, who have more complex issues. They may need more ego support first, and afterwards they can work with more expressive and interpretive interventions.
Thank you
I
so
hope
much.
that answers your question.
Yes, it's been absolutely clear. Thank you so much to both of you, Sibel and Geoff. It's been great to listen to all the enlightening information that you've told us, because I had been noticing this same thing that you both mentioned, that sometimes it's better to start with the support and then move on rather than directly with the psychodynamic expressions. So thank you again.
Thanks, Maria. I know that way back in the 1940s and 50s, you know, mostly in London, but also in the United States, you had two thoughts around that. One thought was the ego psychologist who believed that you should interpret defenses from the surface and then gradually go down and drill down into the interpreting drives or impulses. But you start with the surface. And then the Clinicians, who believe that you interpret very deeply at the very beginning of treatment. And so you go way down into interpreting the drives from the very beginning. And I think what the research, anyway, 60 years later, 70 years later, is telling us is that the ego psychologists were more right about that than the Clinicians, that really, in order to have a more successful treatment, you start from the surface and you gradually move downward into more traditional interpretive work. At least that's how I'm interpreting the more recent findings out of my lab and Sibel's lab. That's what seems to be supportive. I'm very sympathetic to a Kleinian point of view, by the way, but in this particular technique issue, I side more with the ego psychologists, I think. Sibel, you might have some comments about that as well.
I completely agree. That was what I meant. Especially, I mean, this is again a case of what works for whom. For adolescents who are more intact, who have, who are more neurotic, who have better ego functioning, they might benefit from expressive and interpretive approaches maybe right away. For others, like I said, in my research, it was more adolescents with more severe psychopathology, with more severe levels of psychopathology. We found that they needed initially more the supportive context of psychotherapy, perhaps therapeutic alliance, more common factors, before moving on to more specific factors of psychodynamic treatment, at least in the short run. I don't know if this is the case in the long run, but at least in the short run, in short-term psychodynamic therapy, this is what we found.
Right.
So
And I think
completely agree.
it also allows the patient to perhaps experience some relief from their symptoms early on in treatment, which can then facilitate a greater, deeper therapeutic alliance, which can then be used to do the deeper work later on. So I think you want the patient to have some initial feelings of success in the treatment, which can set up the entire treatment for greater success later on. At least that's how I'm viewing it.
Mhm. Absolutely.
And your point is well taken that with certain patients who already have maybe stable ego functioning, they can tolerate a more interpretive stance from the therapist earlier in the treatment. Any other questions before we end? I teach this afternoon, and so I'm hoping that my voice will hold this afternoon.
Okay, I think that's about it for now. There are wonderful comments in the chat thanking you. I would also like to thank you, Geoff, for this presentation. It was extremely rich. I learned a lot, as I always do, from you. I'm very excited about the implications of this work and especially excited to use the prototypes with you in my research. So thank you so much for sharing your work with us, for letting us have this webinar with you. And we look forward to seeing more CPQ and APQ trainings from you, which are always highlights.
Yeah, absolutely. I appreciated it. I appreciate everyone's questions and attention. I'm very excited about this research, and so I'm happy to have shared it with everybody.
So are we. Thank you.
Thank you both so much.
All right. Bye-bye.
Bye-bye.
Thank you.